Hello.
Recording in progress.
సంతోషం.
Hello.
నేను వాట్సాప్ నా బ్యాకప్ ఉన్న వేరే మర్చిపోయినా డిలీట్ చేస్తా డైరెక్ట్ మళ్ళీ అయితే కొత్త వాట్సాప్ అయితే దీంట్లో కూడా పోతుంది కదా యాప్లో కూడా యాప్ కూడా వెబ్ లాంటిది కదా
ఫోనే మెయిన్.
Recording in progress.
Good evening, sir. We'll start within few minutes, sir. We'll wait for the people to join. Then we'll start, sir.
Okay.
Good evening. Am I audible? Okay. Good evening, all. We at Climate Research Solution invite you all to participate in this webinar hosted by the Networking Club interns. I am Kripa Mary Joseph, and I'll be your host for the day. Climate Research Solution is a research organization specializing in clinical research, pharmacovigilance, medical writing, and data analysis. I welcome all the academic enthusiasts to this webinar on the topic Importance and Criteria for De-escalation, Step Up and Step Down of Approach of Antimicrobials and Case-Based Scenarios. For the next hour, we'll be engaged with the session, followed by Q&A, and after that, soon, we'll begin with our panel discussion, and we'll also share the link for the quiz competition, which is the most awaited and excited part of today's webinar. So charge yourself and stay tuned with us till the end. It's with great pleasure and admiration that I introduce to you our esteemed guest of the day, Dr. Ravi Akantikupa sir. Talking about Sir, he has completed his MBBS from Kakatiya Medical College, Warangal, Telangana. He has done his DNB in General Medicine from Sunshine Hospital, Hyderabad, Telangana. He is currently a member of Fellowship of National Board and working in the Department of Infectious Diseases in Apollo Hospital, Chennai. Speaking about Sir's achievement, he had published 2 publications and he received Outreach Grant from ESC MID Global for ECC MID 2024. He received first prize in poster presentation at Neuro ID 2024 from National Institute of Mental Health and Neurosciences, Bangalore. Sir's areas of interest include general infectious diseases and infections in immunocompromised host and HIV medicine. We are very much privileged to have you, sir, with us today. On behalf of Clement and all the participants, I extend a warm welcome to you, sir. I also welcome all the participants to this webinar. I encourage all of you to stay with us till the end and participate in the panel discussion and quiz competition also. Now, I invite our speaker of the day, Dr. Ravi sir, to take over the session. Over to you, sir.
Mute me. Yeah. Am I audible?
Yes, sir, you are.
Yes. Okay. First of all, I thank Networking Club and Climate Organization for giving me this opportunity. Can I share my screen?
Yes, sir.
One minute. Managed to share my screen here. One minute. Now is it?
As mandate.
Now is it visible?
Yes, sir. Screen is visible.
And the slides are moving. The slides are moving.
No, sir.
No.
No, sir.
With this, like I've shared the now the screen is visible.
Screen is
Okay. Slides are moving. It's moving on my screen.
Just try if it works on slide share.
I'm sharing the slides.
Yes, sir.
Slide share.
Next to the maximum button was a maximization at the end, bottom, last one. Down, below. Yeah, that was the last one there.
Start focus mode and stop incoming video.
So you can just share the slide with us, sir. We share it.
Yeah, I have shared the slides with Mr. Sriram already. So share the now is it visible? No,
Yes, sir. Visible.
but the slide is not moving. No, is it moving?
No, sir.
It is moving in my system. Just 2 minutes.
Guys, please unmute yourself if you're not speaking. Please.
Can you help me with this? Like,
Sir, I'll just try sharing the screen. I'll share. So I hope the slides are visible.
yes, yes.
Yes, sir. Let's start.
Good evening, everyone. Sorry for the delay. I thank Climate Academy and Networking Club and Mr. Sriram for giving me this opportunity. Today webinar is a discussion-based webinar and about the importance and criteria for de-escalation, step-up and step-down approach of antimicrobial drugs in daily clinical practice. This is a case-based webinar. Next slide, please. Next slide, please. Next slide, please. Next slide. I'm audible? Yeah, there are no disclosures for the talk. It is not AI prepared. Next slide. It is a case-based webinar. I encourage all to ask questions and answer and participate. That is the only way we can learn. And I'm also a student like you, and I'm also learning. I start with the case. Uh, Now the is my voice clear?
Yes, sir.
Okay. This is a. I'm starting with the first case. This is a patient, Mrs. X. She is a 65-year-old lady. She presented with high-grade fever with chills for last 1 week and associated burning sensation while passing urine and left side abdominal. Next. Am I audible? Now is it clear?
Yes, sir, but I think your voice is
Now is it clear?
yes, sir, now
Okay. So this is a 65-year-old lady. She presented with high-grade fever for 1 week and burning sensation while passing urine and left side abdominal pain. Past history: she is a diabetic and she is hypertensive and she also has renal stone disease and she is a known CKD with baseline creatinine of 3.2 milligram per deciliter. Next slide. And 2 months prior, going into past history, 2 months prior, she had left leg cellulitis, and for which she was admitted to the hospital for 5 days and got treated. There were no recent surgeries. And when she presented to us, her vitals were stable. Her on examination, she had left loin tenderness. So, in clinical practice and infectious diseases, we always say or tell that to look into what is the diagnosis. So always we ask what is the assessment of the problem. So the patient presented with fever, burning sensation in the urine and abdominal pain. So taking into the history of symptoms, we keep a probable diagnosis. That is the first important step. This is also important in terms of antimicrobial stewardship. Uh, So, based on her symptoms, the initial assessment was suspected urinary tract infection, likely left side pyelonephritis. So, she was admitted to the hospital, and basic blood tests like CBC along with blood cultures were sent, along with urine routine and urine cultures were sent. And imaging ultrasound abdomen was done, which was suggestive of left pyelonephritis. And patient was started on antibiotic injection meropenem 1 gram thrice daily and injection tigecycline and was admitted to the general ward. So this is the common cases which we see in hospital, like urinary tract infection. Each and every one of us will see. So from these cases, I wanted to say the important relation step up, step down through the case scenarios. So in this case of suspected urinary tract infection in a 65-year-old lady, uh, we have sent blood cultures and started on antibiotics. So what might be the uh, correct things and wrong things in this patient? Any one of you can chart or keep your answers in the chat box. Nothing. Even if it is wrong, doesn't matter. Just try to answer. Starting this antibiotics, meropenem and tetracycline is correct or wrong?
But actually, your voice is not very clear.
Sorry.
Sir, maybe your voice is not very clear. It's breaking and breaking.
Oh, I'm speaking with the microphone itself.
We try removing the microphone, sir. I think
Okay. Okay. Am I audible? Hello?
yes, sir. You're audible.
Yeah, there seems to be some problem. Now I am audible?
Yes, sir. Now it's coming. Your voice is coming.
Okay, okay.
There are few answers in the chat box.
Yes, yes. Yeah, some way saying meropenem is higher antibiotic and it is indicated only in severe infection. And uh, one of the person was saying meropenem is broad spectrum and it covers broad range of antibiotic. And other was telling meropenem thrice daily can be given if the infection is too high. Yeah, yes, if causing agent is unknown and high infection, broad spectrum can be used. No, we can't start directly with meropenem as it is a higher antibiotic. It is wrong, I think, because both are broad spectrum antibiotics. And how can we give them simultaneously by IV route? Yeah, these were some of the responses. It's very good that you are responding. So, the first thing in clinical practice is we have to see the host. Forget about treatment. First thing, we have to see who is the patient, what are the risk factors for the patient, and what is the diagnosis, then only treatment. Never jump into treatment. So, in this patient, what are the host factors? So, always like you are in your rounds also, definitely you should see uh, what is the patient means what are the host factors for the patient. Is the patient diabetic? Is the patient elderly patient, or patient is on steroids, or patient had any prior surgeries, or patient had prior hospitalization, prior antibiotic use? So all these count are very important host factors to consider an antibiotic. That is most important. There is a difference between community acquired infections and hospital acquired infections. For example, in this patient is a 65-year-old 65-year-old lady. So it's an elderly lady, and she's having diabetes, and she's also a CKD patient, and she's also recently hospitalized within last 90 days. So we say admitted to hospital within 90 days is a risk factor for acquiring drug resistant organisms. So these are all important. We can't just say this is right, this is wrong. Always we have to see the patient. What are the host factors? So if this patient is an elderly patient, she is diabetic, she is having chronic kidney disease, she is recently admitted in other hospital and received antibiotics. So she and she might have some drug resistant bacteria, and the diagnosis, our initial diagnosis is pyelonephritis. So it is a severe infection. We can't say it's a simple cellulitis or like that. So she's having fever, means it is complicated UTI, means pyelonephritis. So in here, uh, starting the patient on meropenem is good enough.
Your voice is breaking again. So could you try joining from your phone if you don't mind? I'll share the slide anyway. So you can just join from your phone. Maybe that would be.
Oh, okay. Shall I log in from my phone?
Yes. Then everything slide.
Just 1 minute. 1 minute.
Yes, sir. Wait a second. Ma'am, will you please unmute, sir?
Yeah, now it is okay.
Yes, sir.
Now it is clear.
Yes, sir.
Yeah, sorry for the disturbance. There was some problem with the microphone or something. So we'll continue. Is it clear now?
Yes, sir. It's clear.
Yeah, thank you. Thank you. Sorry for the delay. So, so this patient we are following, right? So I was telling to take into account the host factors and what is the current diagnosis to decide an antibiotic. There is nothing like high antibiotic or low antibiotic. To always see what is the patient. So in this patient, she has all the risk factors like she's an elderly lady, she's diabetic, she has chronic kidney disease, and she's recently hospitalized for some cellulitis and she received antibiotics. So this patient is a risk, she has a risk factor for having a resistant bacteria. That's what I wanted to say. For this patient, starting meropenem is is okay, is not a wrong decision. But in this patient, starting tigecycline is a wrong decision. Okay, because uh, our initial diagnosis is complicated urinary tract infection, that is pyelonephritis. So for pyelonephritis, uh, is tigecycline a good antibiotic? So no, T-cycline has more volume of distribution. Means it once we give an injection of T-cycline, it goes into tissues directly. Doesn't concentrate into the bloodstream or doesn't have any action on complicated urinary tract infections. So generally, we will not advise tigecycline as an empiric antibiotic for complicated urinary tract infection. So in this patient, meropenem was a okay choice, good choice, but tetracycline is a wrong choice. Okay, next slide. Yeah. So after sending blood cultures, the blood cultures flagged gram-negative bacteria and was identified as carbapenem resistant antibiotic. Yeah. So as we thought, the patient has all the risk factors for resistant bacteria. So she has unluckily she has developed carbapenem resistant bacteremia. So what is the next step? What would you do? So do you escalate antibiotics or what do you do in this at this point? Whatever you feel, you can say. Nothing like wrong or right. Just we are learning from each other. Yeah, some answers that they're saying change to meropenem. Some are telling maybe try to take in combination. So what combination? What combination you want?
Hello, please unmute yourself if you're not speaking. Sir, you may proceed, sir.
Yeah, some are telling we can go to cephalosporin. Some are saying cefepime plus and metazobactam. Okay, so yeah, first we thing is carbapenem resistant E. coli. So definitely we have to escalate. Yeah, good. Some are saying colistin. Some are saying trimethoprim sulfamethoxazole. Yeah, good. So here we have got ceftazidime, avibactam, or colistin. Yeah. So here we have got carbapenem resistant E. coli based on her risk factors, host factors. We have suspected complicated UTI. Her blood cultures also grew carbapenem resistant E. coli. So here carbapenem means meropenem will not work. So we have to escalate in this situation. Definitely we have to escalate. So what are the drugs available for us for carbapenem resistant E. coli for urinary tract infection? So many drugs for carbapenem resistant E. coli, carbapenem resistant organisms like de-escalation is one of the antibiotic, phosphomycin, ceftazidime, avibactam, colistin, as some of are saying, polymyxin B, all are good carbapenem resistant antibiotics. But we have to see the clinical situation. Will T-cycline work? T-cycline is also carbapenem resistant antibiotic used for carbapenem resistant organisms. But T-cycline is not used for UTIs. It is used for skin and soft tissue infections and pneumonias. Next, some are saying colistin. Colistin is a very bad initial drug. Colistin or polymyxin should be used only when we don't have any other choices. Why? Because already you know the patient is CKD. Her creatinine is 3.2. So what is the effect of colistin and polymyxin B on kidneys? So they are more nephrotoxic. So if you give colistin polymyxin in this patient, the creatinine from 3.2 will go to 10 and she will go on dialysis. So always see the benefit and risk of the drugs you are giving. Some are saying ceftazidime avibactam. That is a good option. Some are saying phosphomycin. That is a very good option. Some are saying aminoglycosides. That is also a nephrotoxic drug, nephrotoxic antibiotic. So in patient with CKD, I would not prefer aminoglycosides as a first choice in this patient. Some are saying nitrofurantoin, quinolone, cephalosporin. No, these are antibiotics for community acquired non-ESBL UTIs. This nitrofurantoin, quinolone, cephalosporins. These are for simple organisms which does not have any resistance. Pan sends to E. coli, pan sends to Klebsiella. For those bacteria only, nitrofurantoin, quinolone, cephalosporins are given. Some are saying phosphomycin and nitrofurantoin are not treating UTI. Yeah, phosphomycin is actually a good drug. It is one of the antibiotic for carbapenem resistant bacteria. And nitrofurantoin is not a drug. Nitrofurantoin is for simple community acquired cystitis or simple urethritis. For simple pan-sensitive organisms, it is not used for uh, resistant organisms. Piptas. One participant has given the option of Piptas. Piptas, carbapenem resistant. So for carbapenem resistant, there is we can't give piptas. Okay. So here we have to escalate. Carbapenem resistant. So first we have to see what are the drugs available for treating carbapenem resistant E. coli and proceed along with that. So we have to be very, very careful. Like some of the participant has advised for colistin. Colistin is also a good drug for carbapenem resistant E. coli, but you cannot give in this patient because patient already has CKD. Colistin and aminoglycosides are nephrotoxic drugs which will push her creatinine further up and she might end on dialysis. So it is very important to escalate in a careful manner, seeing the background history of the patient, whether patient has CKD or CAD or uncontrolled hypertension. All these factors has to be taken into account. Okay. Next case. So the first case is a very good example of escalation therapy. Escalation therapy, we have to see what is the organism and what are the antibiotics we can be given, and among the list of antibiotics, which antibiotic can be given to the patient based on patient creatinine clearance, age, all those factors have to be taken. We can't say give cholesterol like that. So carefully see the patient. First thing is do not harm the patient. So giving cholesterol will harm the patient. So we should not harm the patient. See all the list of antibiotics which can be given and proceed accordingly. Okay. Next case.
So there are two questions in the chat box. How is it is evaluated that bacteria is now resistant to particular antibiotic?
How is evaluated pathogen notation? Yeah, in microbiology lab. So you send blood cultures, blood culture, urine culture. In microbiology lab, they will identify the bacteria. What is the bacteria? E. coli, Klebsiella. There are many methods to identify which bacteria it is. After identifying which bacteria like E. coli, they will do the susceptibility testing. We call susceptibility testing means among 10 antibiotics, which antibiotic will work for that E. coli. And the microbiology lab will give the report. So it is very important to talk with your microbiology lab. What is the bacteria? What are the antibiotics that can be given? So the lab will give us the results of that susceptibility testing. Treating cellulitis, what we have given previously. That history is very important. That's what I'm telling. That unfortunately that prior antibiotic history is not available, but admitting to a hospital and receiving antibiotics in last 90 days is a risk factor for suspicion of resistant bacteria. So that history should be taken. That is important. That's what I'm telling. How do we know it is carbapenem resistant? The lab, microbiology lab will provide the resistance pattern of the bacteria. Yes, culture sensitivity, good. Culture sensitivity test. What is conclusion of drug of choice? So in this patient, there are for carbapenem resistant E. coli, there are 3-4 drugs. First drug is fosfomycin. Second drug is ceftazidime avibactam. Third drug is colistin. So among these 3 drugs, I would give fosfomycin for this patient because fosfomycin or ceftazidime avibactam, any one of both, I would give. I would not give colistin because this patient is an elderly patient and her creatinine clearance is less than 30. If you calculate less than 30, and giving a nephrotoxic drug like colistin is very harmful to the patient. So I would not give colistin unless we have no other options. Okay. So I would treat with fosfomycin or ceftazidime avibactam in this patient. That's all. So it's important do's and don'ts we have discussed. This is a case of importance of escalation. Importance of escalation based on the patient, based on the clinical status, based on the laboratory susceptibility tests. Next case. This patient is a 28-year-old patient. He presented with 3 to 4 episodes of loose stools for 3 days, 1 week prior, and fever for 5 days, and on and off vomiting. And there is history of travel outside, and had travel and outside food intake is present. Next, there is no cough, no cold, no sick contacts, no other complaints. Past history, no nil significant. Yes, on examination, his vitals were stable. So, first thing is, what is the assessment? So, based on the patient symptoms, like some loose stools and fever and some myalgias, what is the clinical diagnosis? Always think what is the patient having. Then only we can think of antibiotics. So, the practice of thinking what might be the patient having, like is it a bacterial infection, is it a viral infection, so it will help in uh, antimicrobial stewardship. So if we suspect bacterial infection, we can think of what bacterial infection, so what are the etiologies and what antibiotic can be given. So never jump into treatment, always think what is the patient having. So patient is having some loose stools initially and some fever, so it's a community acquired febrile illness. And one of the participant also said acute gastroenteritis. Very good. Acute gastroenteritis. That is also one of the differential. And it can be dengue or some pneumonia, enteric fever, strep typhus. So we are suspecting few community acquired uh, infections, either acute gastroenteritis or strep typhus or dengue, pneumonia, enteric fever. So for this community, so we are suspecting some bacterial infections. So what will you do next? So basic blood tests were done, and blood cultures are sent, and urine cultures are sent. Malaria, dengue test done, and patient started on metronidazole 500 mg thrice daily, and piptas 4.5 gram IV thrice daily, and is admitted to the ward. Okay, so what do you feel? Participants, please answer. What do you feel about this patient? Common patients we see daily in your hospital. Patient presenting with some loose stools of 4-5 days and fever for 1 week and myalgias. Loose stools, general practice to start metronidazole, and for fever to cover broad spectrum, start piperacin tazobactam. What do you feel? Is it correct? Is it wrong? Not rational. You have to explain. Not rational means what is not rational? Is it giving metronidazole wrong or right? Is it giving piperacin tazobactam wrong or right? So if wrong, what can be given? Piperacin can be used. Piperacin not needed. Piperacin tazobactam is high-end antibiotic. Piperacin tazobactam is wrong. Narrow spectrum. Cefixime plus ofloxacin. Fluoroquinolones can be used instead of piptas. Piptas is wrong. Right. There are few responses. So metronidazole can be used. Yeah, there are few responses. So many responses they are telling like metronidazole can be used, metronidazole can't be used, use fluoroquinolones. So first thing is see what you are treating. So it is just a acute febrile illness with some diarrhea with fever. Now the diarrhea is settled, and there is a misconception that for all acute gastroenteritis or diarrheal syndromes, we have to give metronidazole or fluoroquinolones. So it is not needed. It is a wrong treatment. So metronidazole is for parasites, it's an anti-parasitic drug. So it and anaerobic drug. So there is no role for metronidazole in community-acquired gastroenteritis. Okay, so metronidazole is a wrong option. And ofloxacin. Ofloxacin and cefixime. Yes, ofloxacin, fluoroquinolones. Fluoroquinolones are also generally not recommended for gastroenteritis and acute febrile illness. So, what we are treating here, we suspected dengue, pneumonia, enteric fever, scrub typhus. So, among these, does ofloxacin work for anything? Ofloxacin does not work for dengue, doesn't work for pneumonia, doesn't work for enteric fever, doesn't work for strep typhus. So fluoroquinolones is of no use. Some are saying it's a broad spectrum. Yeah, always say as broad spectrum, narrow spectrum. Don't use the words high and low end. We use the terms broad spectrum and narrow spectrum. So Pipta, some are saying is broad spectrum. It is correct. It is a broad spectrum. It is not high end. It is a broad spectrum. We have to use our words terminology correctly. Next, some are saying cefixime. Yeah, for community acquired febrile illness, for cefixime, what you are treating with cefixime? So enteric fever can be treated with cefixime. Yes, so cefixime can also be given. We can go for further investigation if everything is fine, and we should de-escalate the peptides. Yeah, so. Yeah, here I say that metronidazole is not recommended for community-acquired diarrheal syndromes. It is an anti-anaerobic and anti-parasitic drug. So, in for 1 2 days, 2 3 days history of diarrhea, never give metronidazole. And piperacin tazobactam, it is a broad spectrum in this case. But patient is admitted to the hospital and is having 5 days of fever. It is a broad spectrum, but sometimes okay, we will see the patient. We will see the blood test. One of the participants said we can do further investigation and if see what is the reports and de-escalate immediately. Yes, next slide. Yeah, blood cultures grew gram-negative bacteria and it is identified as Salmonella typhi. What next? So what do so the patient we have sent the blood cultures. It has grew Salmonella typhi. What do you do? Start fluoroquinolones, vancomycin. Okay. Any more answers? Any more answers? Okay. Fluoroquinolones. So, ciprofloxacin. Okay. So here the blood culture grew Salmonella typhi. So the diagnosis is confirmed. It is enteric fever. So what is the susceptibility of enteric fever to fluoroquinolones? How many patients we have seen fluoroquinolones will work for enteric fever? Almost zero. Almost zero. 99.99% fluoroquinolones will not work for Salmonella typhi or enteric fever. And that is the importance of knowing your antimicrobial pattern of your hospital of where you are working. There is high antimicrobial resistance to fluoroquinolones in Salmonella or enteric fever. So fluoroquinolone should not be used in any case of Salmonella typhi. Okay. Next, vancomycin. It is a blunder. We should not use vancomycin. Vancomycin is a very, very high broad spectrum antibiotic and it is used for gram positive infections. Salmonella is a gram negative bacteria. So vancomycin should not be given. It is a crime if you give vancomycin. And I have said ciprofloxacin. There is no role for fluoroquinones in Salmonella. There is high antimicrobial resistance to fluoroquinones to Salmonella in our country. So fluoroquinones are never a drug of choice for Salmonella. Cefixime plus ofloxacin. Yeah, ofloxacin is out. There is no role for combination of ofloxacin in enteric fever. Cefixime can be given. Yes. Ceftriaxone. Yeah, cefixime is an oral agent. Ceftriaxone is a IV agent. So as patient is admitted to hospital, ceftriaxone can be given. So here we de-escalate piptas to ceftriaxone. That is the importance of de-escalation and step down therapy from broad spectrum to narrow spectrum based on your organism, based on your bacteria, based on your AST, antimicrobial susceptibility testing from the microbiology lab. So you have to speak with the lab, see the report, and de-escalate or step down. So here in this patient, we de-escalate broad spectrum piptas to narrow spectrum ceftriaxone, which is sufficient for Salmonella. Third generation cephalosporins, correct. Ceftriaxone is the drug of choice for Salmonella, so we give ceftriaxone. Can we go with aminoglycosides and cephalosporin? No, aminoglycosides is not a drug of choice for enteric fever. Drug of choice are third generation cephalosporin like ceftriaxone. IV, if patient is admitted, we give ceftriaxone. Patient is getting discharged, we de-escalate. We step down to oral cefixime, as one of the participants said. That is the importance of converting broad spectrum to narrow spectrum or de-escalating strategy or step down strategy based on your culture isolates. Okay, thank you. Next. Yeah, these are some of the important theory points like national level antibiotic stewardship program activities can be categorized into basic level, intermediate level, and advanced level. So whichever hospital or whichever college you are working, just form a team among your friends, form a team among your pharmacists, and like most of them would be working in basic or intermediate level colleges or hospital. So develop a formulary, create and promote adherence to evidence-based treatment guidelines for common clinical syndromes. That is most important. So in previous case, we have seen it is a case of enteric fever. So, it's a clinical syndrome of enteric fever. So what are the drugs can be given? What is the first line recommended drug? Based on that, you should decide. Okay. So you have to very thorough in your uh, pharmacology. What antibiotic can be given to what bacteria? Some of the participant has said vancomycin. That is very false. Vancomycin is a gram-positive antibiotic, and Salmonella is a gram-negative bacteria. So it doesn't work. It is false. So you have to be very thorough in your antimicrobial stewardship. Next slide. Next slide. Next slide. And the following items are daily activities that also should be performed by a pharmacist. So all I know I have many of my pharmacist friends. They daily do rounds, clinical rounds with the patient. They go through the drug chart, whether dosing is correct or not. the frequency is correct or not, whether it is adjusted to creatinine clearance or not. So these are all very important in reducing the antimicrobial resistance, and also very important in your antimicrobial stewardship practice. So daily you should review antibiotics for unnecessary duplicate antibiotic therapy, such as double aerobic cover like piptaz and metronidazole. Both are not required. Piptaz also has aerobic cover, metronidazole also aerobic cover. So any one of them should be given. So if you find any drug chart, both peptides and metronidazole are going, speak with your doctor, speak with your clinician, treating physician. Sir, is both antibiotics are required in this patient? Just ask with them, talk with them. So they will also say a few points. You will also learn from them. Always cross check with your treating physicians, and double MRSA coverage. Like some patients will be on clindamycin and teicoplanin. So both are MRSA. So when you find both clindamycin and teicoplanin drug chart, speak with the treating doctor. Sir, is both anti-MRSA drugs required in this patient? That is, we have to do daily. Next, review opportunities for intravenous to oral conversion. As we have seen in the previous patient, we have given ceftriaxone in the IV during the IV ceftriaxone in the admission, and we have de-escalated or stepped down to oral cefixime at discharge. So when you find any patient going on IV therapy to home, ask your treating physician, sir, is IV therapy required for this patient at discharge? Can we step down to any oral antibiotic? Ask, always you have to ask. Next, monitor for medication safety, renal dose adjustment. Yes, so as we seen in your first case, um, some of them were saying colistin. So in a CKD patient, it should never be given. So always see your renal dose adjustments. And though they represent general pharmacy practices are not specific to stewardship, but in your daily rounds, in the hospital or college, always go through the drug chart, do all these things, speak with your doctors or treating physician. Any mistakes you have found or any dosage is wrong, frequency is wrong, or the antibiotic is not adjusted to the creatinine clearance. All this you have to talk with your treating physician. Then only you will also learn. Next. Yes. Two more cases. The patient, Mr. C, 50-year-old patient, presented with fever, cold, dry cough, and myalgias for 3 days. There is history of attending a gathering 2 days prior to symptom onset. There is history of similar symptoms in the spouse. Patient is a diabetic patient and no other comorbids. So what do you think? On examination, his vitals are stable. So what do you think? Uh, what is your diagnosis based on patient symptoms? As I have been telling many times, always see what your patient is having, what is the diagnosis, then only think of treatment. Don't jump to treatment. Forget treatment. Just think what is the patient having, what might be the patient having. Like, is it a bacterial infection? Is it a viral infection? Because your antibiotic stewardship depends on whether it is bacterial or viral. If it is bacterial, you give antibiotics. If it is viral, there is no need for antibiotics. So you are doing good for antimicrobial stewardship, and you are reducing the antimicrobial resistance by not giving antibiotics in a viral infection. So in this patient, he has fever, cough, cold, and he has travel also. He has any day function and similar symptoms in the spouse. So it's looks like a respiratory viral infection, uh, and it can be dengue fever also. Um, Next, blood tests were done, and dengue serology was negative, and patient was started on ceftriaxone and azithromycin. Patient was admitted to the hospital. It's a common case you see daily. He's a diabetic patient, 55-year-old. He's having some fever, some cold and cough. So he's admitted to the hospital, and the treating physician starts antibiotics, ceftriaxone and azithromycin. Next. So what do you think? Is it right? Is it wrong? Participants, please answer. So viral infection wrong. What is the wrong in this patient? Flu. Yeah, flu. So I'm asking about ceftriaxone and azithromycin. Is it right? Is it wrong? Wrong. Yeah. So yeah. So admitting to hospital, the treating physician has started ceftriaxone and azithromycin, but after initial evaluation, it was found that H1N1 was positive. So here there's a chance for step down and stopping the therapy. So H1N1 is positive, it is a viral infection. So there is no need for antibiotics as it a viral infection. So we would stop ceftriaxone and azithromycin. There is no wrong to give antibiotics in a IV admitted patient, but after your diagnosis, you stop the antibiotic. That is the importance of step down or de-escalation or stopping. Okay. So initially we don't know before the H1N1 report has come positive. We don't know before the X-ray. We don't know patient must be having some pneumonia also. So initially when we don't know the diagnosis, starting a narrow spectrum antibiotic, there is no wrong in it. So ceftriaxone erythromycin is a narrow spectrum commute acquired antibiotic. So there is no wrong in giving that. But once your diagnosis is made, like your chest X-ray is normal, WBC count is normal, and H1N1 is positive, on the same day, you are confirming that it is a viral infection and you stop antibiotics. That is the importance of de-escalation and stopping. Yeah, we can, yeah, Tylenol. So here in this patient, uh, oseltamivir, Tamiflu, that is sufficient, uh, along with some paracetamol. No need for antibiotic. So this is the importance of stopping the antibiotic, and you will reduce the antimicrobial resistance by careful clinical decision. Okay. Yes, oseltamivir and supportive care. That is correct. Next. Yeah, key opportunities to improve antibiotic use. So we have been discussing for the last 1 hour. So there are three common clinical syndrome where we can improve antibiotic use. Like one example is commute acquired pneumonia. So in cases of commute acquired pneumonia, we have to review all cases at 48 hours to confirm pneumonia or not. So in the previous case, we have admitted the patient, we don't know whether it is pneumonia or not. We have started some antibiotics. At 48 hours, our reports will come, like X-ray has come, H1N1 report has come, WBC count has come, all are normal, H1N1 is positive. So it is confirmed viral. There is no need for antibiotic. We'll stop antibiotics, ceftriaxone and azithromycin. So antimicrobial stewardship practice. And starting a narrow spectrum antibiotic like ceftriaxone, erythromycin, I'm saying it's not wrong in this case because we have reviewed the patient after 48 hours and we have stopped. Okay, so that is the importance. Starting broad spectrum antibiotics, say in this case, if we would have started piptas, it would have been wrong. It is a broad spectrum. It is not required. We are suspecting viral infection. So starting a broad spectrum is wrong. We should start a narrow spectrum, see the patient again at 24 hours, 48 hours, and decide on antibiotic. Okay, so antimicrobial stewardship is a daily practice. It's not like once a time. Every day you have to review your drug chart. Every day you have to do your dose adjustment of antibiotics. So that is very important. Next slide. Similar to UTI. In the first case, we have seen. So we have to establish criteria to distinguish between asymptomatic and symptomatic bacteria. And fluoroquinolones are often not optimal empiric therapy. So in the first case, we have seen it is a complicated urinary tract infection. So patient has fever, patient has burning micturition. So it is a symptomatic UTI. In some patients, they won't be having fever. And we would have seen I suppose most of you have seen routinely urine cultures have been sent without patient having any symptoms. That is wrong. So we should not treat the reports. We should treat the patient. So see the patient, then only make your diagnosis, then only start antibiotics. Don't see the reports and treat the patient. Next. Third, skin and soft tissue infections. So skin and soft tissue infections also you should divide into either it is severe or mild or moderate, or is there is pus or no. So for mild infections, you can get away with 3 to 5 days of antibiotics. For severe infection, you need to give more duration of antibiotics. So based on that, you have to decide our antibiotics. So these preclinical syndromes are the commonest clinical syndromes like UTI, commute acquired pneumonia, skin and soft tissue infections, where there is lot of opportunity to de-escalate, escalate, step down, step up antibiotics. Apart from this, there are many other things. So you can't restrict to these three. In daily, in your hospital, college, you have seen number of patients um, who are on irrational antibiotics or who are not on rational antibiotics. So it is a day-to-day practice. Next. The last case for the session. So this patient is a 60-year-old patient, male patient, presented with fever, abdominal pain, vomiting for last 1 week, and admitted elsewhere for 3 days. And later he had persistent fever and new onset hypotension. He shifted to our hospital. Patient is a diabetic, hypertension is a chronic ethanolic, and on admission he is having a hypotension. So patient is having sepsis, and he's also having a central line. So what is the syndrome? As I have told you, what is the patient having? Patient is having fever, abdominal pain, and vomiting with hypotension. So it is a sepsis syndrome. Patient is sepsis syndrome. Sepsis means mostly it's a bacterial infection. So what might be the bacteria? What is the source of the sepsis? So patient is having abdominal pain. So it can be abdominal source. Like it can be pyelonephritis, it can be intestinal perforation or acute pancreatitis. It can be any of these. So based on your symptoms, you say this is a diagnosis. Our diagnosis is sepsis, likely abdominal origin, like pancreatitis, pyelonephritis, or intestinal perforation. And patient is already admitted in other hospital for 4 or 5 days. He received antibiotics, and he's not improving. He came to our hospital and is also having hypotension. So it is septic shock. Patient is in septic shock. So we have to act fast and give antibiotics. In this patient, what would you do? What antibiotics would you give? I'll come to questions at the last. So in this patient, what antibiotics? What is the syndrome? Our syndrome, we have told it is a septic shock syndrome with abdominal origin. Okay. So we have sent blood cultures and patient started on meropenem, teicoplanin, and fluconazole. So is it correct? Okay, meropenem, ceftriaxone. No. So in this patient, meropenem is okay. Yeah. In this patient, he's having septic shock. So already he's admitted in other hospital and received antibiotics. So I'm suspecting a resistant bacteria, and he's having septic shock also. So we should be very careful. Septic shock is an emergency. We can't wait. Okay. So ceftriaxone. Ceftriaxone is a antibiotic for simple bacteria, non-sensitive, pan-sensitive bacteria, non-ESBL bacteria. Here patient is having septic shock. He has received antibiotics. So we should not use ceftriaxone. Okay. Teicoplanin is given for soft tissue infections. Yes, teicoplanin is given for soft tissue infections. It is also given for gram-positive coverage. For any gram-positive severe infections, it is a broad spectrum antibiotic. Always learn your antibiotics, whether it is broad spectrum or narrow spectrum, to which syndrome it can be used. Teicoplanin is a broad spectrum gram-positive antibiotic. It can, what are the clinical syndromes where it can be used? So it can be used for gram-positive severe infections like skin and soft tissue infections, pneumonia, abscess. Okay, vancomycin. Vancomycin is also broad spectrum gram-positive antibiotic. So it can, broad spectrum means it can cover resistant bacteria. The meaning of broad spectrum is it will cover resistant bacteria also, like MRSA, gram-positive MRSA, Enterococcus faecium, like that. Okay, linezolid, yeah, linezolid is also gram-positive broad-spectrum antibiotic. Yes, yeah, some are saying polymyxin. So polymyxin, yeah, but uh, as I'm saying, so as an empiric choice, polymyxin is not a very good drug. So unless you know what is the bacteria and unless you know the creatinine status of the patient, don't use nephrotoxic drugs like polymyxin. Polymyxin is the last antibiotic you should choose. Okay, it should never an empiric antibiotic. Okay, so in this patient, we have tried on meropenem, teicoplanin, and fluconazole for covering resistant gram-negative bacteria and gram-positive, and also fungus. Next. So the blood cultures we have sent and the blood culture group gram-positive yeast and identified as Candida auris. So what would you do now? What is Candida auris? Is what is that? Is a resistant fungus or it is a sensitive fungus? Any idea? Anyone has any idea? It's a fungus, right? So it is a resistant fungus or it is a sensitive fungus? What antifungals can it be? Can we give? Already we have started on fluconazole. Is fluconazole sufficient or we need to escalate in this patient? Yeah, so you should learn more. Candida auris is not a sensitive fungus. It is a highly resistant fungus. High fluconazole will not work for Candida auris. Okay, so it is a highly resistant fungal. No. Posaconazole is should not be given the drug. So we should read your theory more. Okay. So drug of choice for Candida auris is echinocandins, another class of antifungals. So we have to step up. we have to change the class. Azoles are not drug of choice for Candida auris, echinocandins. I know you have learned in your pharmacology, there are many classes of antibiotics like azoles, echinocandins, polyenes, all these. Among these, for Candida auris, only echinocandins should be given. Azoles are resistant. So, as uh, as said, you can give caspofungin, avulafungin, or micafungin, any of the echinocandins. So this is an example for step-up therapy. So based on your bacteria, based on your fungus, based on the susceptibility of the bacteria, whether it is uh, carbapenem sensitive, carbapenem resistant, whether it is community acquired, hospital acquired, based on that you should decide your antibiotic therapy. So this case is important example of step-up therapy. We have isolated Candida auris. So based on that, we have stepped up from azole to echinocandins because azoles will not work for Candida auris. So this is an example for step-up therapy. Next. Yes, what next? So we have seen that we have to step up to echinocandins based on the fungus which we asked. So this is an example of antimicrobial stewardship course. This is a free course provided by WHO. This is freely available online on openwho.org. So this is a free course. I have not done this course. I should also do this. I suggest all of your to pharmacy colleagues to please complete this course. Many of them have said that this is a good course. It's a free course. You will get a certificate at the end of completion. So please do it. Next, you will learn more from the course. And this is also another example of online source material available in stanfordonline.com. This is also a course on antibiotic stewardship, improving clinical outcome by optimizing of antibiotic practices. This is also a free course, and you will get a certificate at the end of completion of course, and you will learn many more things on escalation, de-escalation, step up, step down, what antibiotic should be given to what clinical syndrome. You learn many things. So please, I suggest all of you to complete the course. Next. And this is app. This is app up by our Indian Council of Medical Research, ICMR. Um, this is a free app available on Google Play, and this is a treatment guidelines app was prepared by ICMR by many of uh, senior doctors from our country. So you will find many guidelines like for enteric fever, what antibiotic should be given, what antibiotic should not be given, what are the first line antibiotics. So many of the important clinical syndromes for pneumonia, UTI, enteric fever, cellulitis, what antibiotics can be given, what should not be given. These guidelines are there available freely on the app. So I request all of you to download this app from Google Play and go through daily in your rounds. When you go for rounds or college, you read a topic, just open the app and see what is there. So what they are suggesting. So if you see daily only, you will remember. Otherwise, you will forget. Next slide. That's all. So this is the importance of a few case examples of importance of escalation, de-escalation, step up and step down. These are very important practices to reduce antimicrobial resistance in our country. So India, our country has very high burden of antimicrobial resistance. As some of you or most of you know, we are in a crisis of antibiotics. There are very few antibiotics left for treating multi-drug resistant organisms. So we have to use our antibiotics, our broad spectrum antibiotics very carefully so that will reduce our antimicrobial resistance and will save our patients. So patient acquiring multi-drug-resistant bacteria, there is mortality and morbidity. The risk of death is very high. So we should not encourage broad spectrum antibiotics left and right just like that. Always follow the principles of escalation, de-escalation, step up, step down for each patient, as we have discussed through few of the case examples. So download the app, complete the 2 online certificates, daily talk with your treating doctor, ask your doubts, uh, learn more about antimicrobial stewardship. It is very important in reducing the antimicrobial resistance in our country, which is a huge problem. Okay, thank you.
Thank you, sir. Is there anyone having any doubts or questions? You can unmute yourself and ask, or you can type it in the chat box.
Thank you. Thank you.
I guess nobody is there with a doubt. So
Yeah. Yes.
thank you very much, sir. On behalf of all the participants, I would like to extend a deepest appreciation to our esteemed guest of the day, Dr. Ravi, sir. Your valuable contributions have enriched our understanding and provided us with actionable takeaways. Your willingness to share your knowledge and experiences has enriched our understanding and provided us with valuable perspectives. We are grateful to you, sir, for the time and effort you invested in preparing for today's session and for your engaging presentation that captivated our audience. Thank you very much, sir.
Thank you very much. Sorry for the initial glitches. There was some problem with the microphone. I hope all went good. And thank you for the opportunity also. Thank you.
Thank you very much, sir.
Thank you. Thank you.
So guys, now we'll proceed with the panel discussion, and soon after this, we'll be having the quiz competition. Link will be provided, and it's mandatory for all the Climate interns as it will be considered as your attendance. So stay tuned with us. And now let's move on to the unique part of today's webinar, panel discussion. We have selected 5 of our student participants as today's panelists to explore a brief overview on the topic real-life experience about antimicrobial resistance. Let's hear from them their unique perspective thoughts. As we navigate this discussion, let's leverage our collective knowledge, experiences, and ideas to gain a deeper understanding of the issues at hand. Without further delay, let's embark on this insightful journey together. We'll aim to wrap up with a Q&A session where you can pose your questions to our panelists. I congratulate all the top 5 selected panel members. Now, let's meet our panelists who will bring a wealth of knowledge and expertise to the table. Each one will briefly introduce themselves and share why this topic is important to them. Before moving on to the panel discussion, let me remind the panelists that be within your time limits so that it will be easy. Now, first of all, I'd like to invite our first panel member, Dr. Sadia Rao. You may introduce yourself and move to your topic. Over to you, Dr. Sadia.
A very good evening, everyone. This is Satya Rao, a family PB intern from Sultananum College of Pharmacy, Hyderabad. I'm here to share a little info about antibiotic resistance. Nowadays, I see a lot of students posting certification on antimicrobial stewardship. But I request you to not to just post the certification, but contribute your knowledge to the healthcare system. So first, let's have a brief outlook for what is antibiotic resistant, how does it happen, and how does it affect us and healthcare system. Antibiotic resistance means when a bacteria develops resistance to the antibiotic, and this process is called natural selection. This is due to continuous and misuse of antibiotic, and that is why our treatment for infection is no longer effective. Now, some of the examples of antibiotic resistance are, anybody can come up and say what are the examples. Just now we had a case on CRE, that is carbapenem resistant E. coli. So here are the examples that are MRSA, that is methicillin resistant Staphylococcus aureus, CRE, that is carbapenem resistant Enterobacteria, MDR TB, that is multi-drug resistant tuberculosis, and ESBL, that is extended spectrum beta-lactamase bacteria. Now, how they develop this resistance? The reason can be, I'll not go much deeper into that. I'll just outline the processes. The first one is genetic, they have genetic material. So the random mutation, the bacteria undergo random mutation and they changes the DNA. Hence, they have the potency to change the DNA. Hence, they can produce a resistance. Then bacteria exposed when too much to antibiotic, they can have an survival advantage. The survival advantage can be done by chemical alteration of antibiotic or destruction or decreased penetration of antibiotic into the cell wall or by changing their target site. And one more process is gene therapy. Now, what are the consequences? You guys can add up one or two lines if you are aware of. What are the consequences of antibiotic resistance? Due to antibiotic resistance, we will have severe illness. Severe illness can lead to increased mortality rate. Yeah, failure of therapy, longer treatment duration, death, yeah, that's what increase in mortality rate is. So, and severe illness also can lead to increased treatment and healthcare service costs. Nowadays, this is the most important thing going on there, that has been spike up, that is increase in healthcare and treatment costs. So now we will say prevention is better than cure. So what are the preventive measures we can take for preventing this antibiotic resistance? You can add up points. Come on, guys, in the chat box. What are the preventive measures we can take? Culture sensitivity, lab culture before treatments. Yeah, these are just the diagnosis. What are the preventive measures? Yeah, that's right. That is rational use. We should use the antibiotic effectively and prevent the infection by vaccinations. Vaccinations are much more good enough for preventing the infection, and practice good hygiene and spread education and awareness for effective use of antibiotic. And if you are a healthcare worker, then you should support the research and new innovations. Now I'm here to share up my real life experience of antibiotic resistance that I was doing my internship, and I came up with a very crucial and critical case that was of MDR-TB, that is multi-drug resistant tuberculosis. This is antibiotic resistant when tuberculosis and Mycobacterium tuberculosis is resistant to potent anti-TB agents, that is rifampicin and isoniazid. Then the patient name was Ram Gopal Verma. He was 49 years old. Obviously, sex was male, and he came up the previous history. This is most important. The previous history. He was on. He had TB, and he completed his 6 months of treatment of He was having anti-TB drugs for 6 months. So he came up with the symptoms of cough, chest pain, fever, and weight loss was drastic and due to loss of appetite. He was saying that he was unable to have food and he was not liking to have food. So when he came back with these symptoms, we were so furious to know what is this happening, because he was for a long period of 6 months he was having the anti-TB drugs, but the symptoms came up and there is nothing changing his health. So we came back. When we came in front of him with a long query, we were asking him what was the reason. So it can be like inappropriate drug regimen, or poor adherence, or he didn't show up for follow-ups, or he came in contact with a TB patient, or he has misused the drugs, or nowadays fake drugs are most rotating in the market. So he may have a fake anti-TB drugs, so that the treatment is not working on them. But so prion to our to prion to take next step, we suggested him for a pre-evaluation of complete health, like height, weight, blood test, urine test, sugar test, chest X-ray, etc. So we found that he had low BMI, then high sugar levels, and in his chest X-ray we can see opacity of masses on the lobes of lungs. And here, our doubt was the resistance, because we were giving him the first line treatment for TB, but it was not working on him. So our doubt was the resistance. So we suggested him for a test, that is Haines test. Haines test is nothing but it is also called as LPA test. LPA is line probe assay. Haines test is used to detect tuberculosis and drug sensitivity of anti-TB drugs. In that, amplification is they will isolate the DNA, then amplify it, then fragmentation will take place, then they will get to know the specific gene resistance. So it will take almost 5 to 10 days accordingly to the diagnosis, respective of the diagnosis centers. So some will take 5 days or some will take 10 days for the results. So when we got the result from the Haines test, we found out he was resistant to rifampicin and isoniazid. So then after that, we started him a new therapy for TB, and that was TB therapy requires 21 to 24 months approximately. So first is initiative phase. We will give 6 drugs for 6 months. Now isoniazid and rifampicin is vanished. We have to add a kanamycin, that is 750 mg 6 days of a week. Then ofloxacin 1000 mg twice a day, ethonamide 750 mg twice a day, paracetamide 1500 mg once a day, ethambutol 1200 mg once a day, and cycloserine, that is 750 mg BD. How can we measure the dose? These doses are based on the body weight. So they are divided into 4 categories according to the body weight. So less than 55 have certain value, then 55 to 75 will have certain value, and more than 75 will have other value. So this dosing can be done by considering the body weight. So then the patient was suggested to review after 4 months. This is the initiative phase is of 6 months, but we suggested him to come back after 4 months so that we can see his culture. If the culture is negative, we can shift into the continuous phase. If not, we should continue the treatment for 6 months. The continuous phase is nothing but we will have 4 drugs for 18 months. That is ofloxacin, ethonamide, ethambutol, and cycloserine. Then after the follow-up of cultures is scheduled during the treatment, every end of the month he should come up, and the early morning sample is tested. So our role is very important because I don't say that doctors don't do, but the most important part is we should guide for the optimal use of antibiotics by reducing the unnecessary antibiotic use, monitoring and reporting if we see any, and educate the public about the not misusing the antibiotic. So thank you very much, Clement and Dr. Ajit sir, for letting me share my little info in front of you. I'm also not a teacher, but I'm still learning. Uh, so thank you very much.
Yeah, that was a well articulated one. I have a few questions to you, like
Yeah,
how
sure.
rifampicin developed resistance? How?
When we
Yeah, you
perform the healings, can I go with the answer?
yes, of course.
When we perform the Haynes test, which is used to detect the drug sensitivity, the detection showed mutation in PROB gene. PROB gene indicates rifampicin sensitive. PROB gene is the gene which rifampicin family targets. And in this test, isolation, amplification, fragmentation, and stripping is done. And if we find mutation in PROB gene, then it is rifampicin sensitive.
Okay. And describe about therapeutic drug monitoring of vancomycin in short.
Okay. Vancomycin, it is important for TDM of vancomycin because therapeutic drug monitoring is done to ensure the drug concentration in blood and prevent toxicity and avoid suboptimal therapy. So rifampicin is a nephrotoxic drug. So it is important to have TD of vancomycin. It is about 10 to 50 per L, the concentration, and the AU and AMI ratio should be maintained to 400 to 600 to have maximum effect and minimize toxicity of vancomycin.
Okay. A final question, that is, how long does it take to obtain tuberculosis positive culture report?
Okay, for culture reports of tuberculosis, we have 3 tests. That is skin tuberculin test, where it will take 48 to 72 hours. So in that, we will have the Montauk's test and skin formation or skin lobe is seen. And if it is more than 5 mm, then it is positive. So, and the blood, if you are going with blood culture, it will take 24 hours. And if you are going with Haynes test, it will take 5 to 10 days.
Okay. Thank you, Sadia, for sharing your valuable input.
Thank you so much.
Okay. Now I call upon a second panelist, Aftab Alam, to speak on the topic. Over to you, Aftab.
Okay. Good evening to everyone. Am I audible?
Yes, you are.
Yes. Good evening to respected Dr. Teja sir, and Dr. Ajit sir, and respected interns. Now I start with the antimicrobial resistance. So as we have studied in this session, what is AMR? The AMR is a critical global health issue where microorganisms as bacteria, fungi, and viruses are resistant to the antimicrobials. So there are very mechanisms involved in the resistance. So someone like to tell what are the mechanisms involved for the antibiotic resistance? So basically there are 3 mechanisms: natural resistance, acquired resistance, and cross resistance. So yes, correct, DNA mutation. So it all kind of done with the mutation of the genes in the microbes. Some are the naturally resistant to antimicrobials, for example, metronidazole. Okay, so metronidazole don't work for the aerobic organisms. Yes, works on the anaerobic microbes. So this is the natural resistance, cross resistance are the same category in observed. Okay. So why is the AMR is a threat? Okay, so AMR is not only occurred in the humans, not only occurred in the humans, it also observed in the animals and agriculture. So it's a worldwide threat. Okay, so AMR is the major major threat for the world. So AMR arises primarily one of consequences. The consequences of AMR are fast reaching. It limits the effectiveness of antibiotics and other antimicrobial drugs. So it can lead to the first what? Failure of the therapy, okay, less in effectiveness of the therapy, long duration of the therapy, okay, increase the hospital stays of the patient, okay, and increases the chance of the what? Nosocomial infections, right? Nosocomial infections are the most fatal one to be observed. So if the patient encounters with the nosocomial infection, it can lead to many multiple body infections. So next is the death. For death is the last one, and it also causes the super infections. Okay, so very much fastly doctor prescribe the broad spectrum antibiotics. So broad spectrum antibiotics mainly cause the super infection, may exacerbate the other infections in the body. So we in this session always ran a talk about the antimicrobial stewardship programs. So anyone want to tell what is antibiotic stewardship? So antibiotic stewardship, if we talk about, so I will talk about the antibiotic stewardship on the 3 parameters. Okay, so on the antibiotic stewardship can be of doctor level and nurse level and pharmacist level. So first I will cover the points of the clinical pharmacist. So as the clinical pharmacist, what are the roles and responsibilities? So antimicrobial stewardship programs. So when the clinical pharmacist are the responsibilities as the now when they take the ward rounds. Okay, so we the ward rounds always review the medication charts of the patient. Always observe what is the condition of the patient is the most important. Always making sure the what is the patient condition, what is the disease diagnosed in the patient. Disease, what is the disease, is the culture test performed or not? So culture test education is knowledge, basically is the most important thing in these stewardship programs. And also observe that the antibiotics is rightly prescribed or not. Or if you feel that the antibiotics are not rightly prescribed, ask the doctor or talk with them or consult with them, is the right choice or not. So you can or discuss to clear the doubts. At the dosage form or frequency, duration should be you have assessed. This is the responsibilities. So as the stewardship is not the one person is a role, nurse also play in this. So you have observed that the nurse are the people who collect the samples, right? So nurse collect these blood samples and urine samples. So always nurse sometimes not pay attention to the collection of blood samples or urine samples. So when many times what happens ki urine sample is not collected but contaminated by the nurse during the collection or during the sending to the microbiological labs. Blood samples sometimes got contaminated due to the incorrect collecting techniques to the microbiological labs. So nurse also plays roles in the antimicrobial stewardship program. So last is the doctor. So during the doctors, like the surgeons who do the operations, always they should pay attention to the correct sterilization techniques. Okay, and the microbiological labs, so they can should pay attention to the correct sterilization technique too for determine the culture test. Okay, sometimes the sample is contaminated, so cross contamination may occur. So wrong microorganism may isolate on the culture. So the doctor may can prescribe the wrong antibiotic, or doctor may can prescribe the wrong antibiotic due to the less awareness or the less knowledge of the guidelines. So important is the guidelines. Okay, so WHO guidelines or other guidelines of the specific infectious diseases should be always studied by the students. Have always spread the awareness about the antimicrobial stewardship. and last is the I tell the research. So always we in a talk tell the less antibiotics are less sorry, less antibiotics are there in the pipeline. So we now who are the researchers or the aspiring researchers should pay attention to the time, right? Pay attention to the research for the new antibiotics development. Okay, so new antibiotics are should be discovered, because the many you saw and observe in the hospitals like the septic shock patients or multi organ failure patients, many antibiotics don't work due to the late culture sensitivity test or late culture susceptibility test of the antimicrobials. So this is the major problem observed. Or also we have to as the clinical pharmacist during the internship or ward rounds, you have all interest, so you have to play role the antibiograms. Okay. Every hospital has the fixed antibiograms, right? So anyone has know what is the antibiogram can write in the chat box. Antibiogram. Yes, spectrum of activity. Yes, correct. So antibiograms of the hospitals or the, you can say hospitals or the area, okay, localized areas fixed. So you can always play role in the study or the research of the antibiograms, so you can now get the idea what are the antimicrobials usually majorly used in our hospitals, so that the you have role you can play, you can play in an infection control committee of your hospital and the PTCA committee. So you have something like you have to change in these guidelines you feel, so you have the opportunity to play a role in that also. So I am a 5th year student. So as an experience, I encountered the one experience of the antimicrobial resistance. So in the 4th year, last year, in the pediatric posting, I've encountered the case of a pediatric patient, 7-year-old patient admitted in the pediatric ward, diagnosed with the pneumonia. Admitted in the ward, diagnosed with pneumonia. So where there the doctor prescribed the vancomycin for the treatment of pneumonia. So you all know, right, ki vancomycin is the broad spectrum, right? Broad spectrum antimicrobial.
Of the
Okay.
hello, please.
Vancomycin being the broad spectrum antibiotic, you have no role in the pneumonia treatment, right? So vancomycin are majorly used in the complicated infections or the ICU infection, emergency infections. In the pediatric population, vancomycin is not the right choice for the pneumonia, and has the community acquired pneumonia. So vancomycin is not the right choice. So that the case I encountered also, and the vancomycin dose or vancomycin is not stopped and that case. So I have encountered that case. Thank you.
Okay,
If someone has questions, can ask.
have a question to you. Why specifically irrationality occurs in patients with polypharmacy?
Polypharmacy, yes. So polypharmacy, that condition when the more than two, three antibiotics or the drugs being prescribed by the doctor. So polypharmacy is the condition mainly observed in the old age patient, geriatric patients. So old age patients have the mentality that the one doctor treatment is not sufficient for him for the treatment, right? So what happens is when a patient goes to the one doctor, get the prescription, get the drugs, take the medicines for the 2 to 3 days, stop the medication that he or she thinks that the treatment is not working. So here he or she might go to the other doctor or the other doctor for the treatment. So in that course, what happens ki resistance occurs in the drugs or majorly observed in the antibiotics. So yes, polypharmacy is the most observed conditions. It can lead to ATR, it can lead to interactions. So not good.
Okay. How can we treat a gram-negative bacteria like enterobacterials if all the drugs except colistin, polymyxin, abibactam, and aztreonam are resistant?
Gram-negative Enterobacteriaceae. Okay, Enterobacteriaceae are the most pathogenic bacteria observed in the UTI, respiratory infection, cardiac infection, etc. So polymyxin, ceftazidime are resistant. So what in our first choice on our depend on the case. We have to observe the case mostly. What is the current condition depends. Always have to do the culture test. Always do the culture test is the prime responsibility. Do the culture test, observe the what antibiotics are sensitive, and observe the MIC value of each antibiotic. Antibiotic who's sensitive, that in case should be used.
Okay. When to suspect septic shock?
Septic shock. Septic shock you have mostly you will see in the emergency departments only. Septic shock is the most complicated condition, I say, is the very fatal one. So when as septic shock, sign symptoms are the hypotension, totally disrupted electrolyte value, okay, and symptoms like the and tiredness, headache are observed. Multi-organ failure is observed mainly.
Okay, thank you, Aftab, for the noteworthy exposition in your thoughts.
Thank you so much for giving me this opportunity. I'll very happy to share my experience and things. Thank you so much.
Thank you. Now I invite Lokesh Hira Singh to share his experience. Here you go, Lokesh. Lokesh, are you there?
Hello,
Yes.
I'm
Proceed.
visible. I'm audible.
Yes, you are.
Myself, Lokesh Hira Singh. I'm currently in third year PharmD. I'm pursuing my PharmD from Meds Institute of Pharmacy, Nashik. I would like to thank Dr. Sadia and Aftab Alam to sharing their experience. It helped me a lot to gain the knowledge of theirs. It would also help me to guide myself for the future endeavors. Let us be like, I would start with basics. I don't know much about antimicrobial stewardship program or resistance. I would share something about Staphylococcus infection. As we know, Staphylococcus infection is the notorious infection. It is Staphylococcus infection is mostly susceptible to every soil. It is resistant to every antibiotics except for broad spectrum antibiotics like vancomycin and linezolid. How Streptococcus aureus is resistant towards some of the bacteria. I would like to explain some of the antibiotics. Let's take an example of streptomycin. Staphylococcus aureus usually alters a target site for the streptomycin so that it could not bind to the targeted site, and it helps the bacteria to resist itself. And for aminoglycosides, it inactivates the plasmid dependent and alters the target site. Sorry. Uh, sorry.
Hi, Lokesh. Keep calm. Just keep calm and then speak, okay? Just keep calm. Nobody is judging you here. Just keep
Yeah,
calm.
sir. Sorry, sir.
Nobody is judging you. Just keep calm and then speak.
Yeah.
We have a lot of time, okay? Speak aram se. Just chill.
Sorry for the inconvenience. Let me proceed. What happens if a drug is resistant, if an antimicrobial agent is resistant? Means like we are on the verge of using the last resort of our antibiotics. If the last resort of antibiotics is also becomes resistant, what would be the consequences? Can anyone give some example? Okay, let let me be with the answer. If we are on the verge of extinctions of the antimicrobial agents, which are so that we cannot use many of the antibiotic agents. Ah, sorry, sir.
Lokesh, you can continue. We are here. Be calm.
Sorry.
No issues, no issues. Stay calm and proceed.
Uh, can you be? Can you ask someone else? Sorry.
Are you sure?
Yeah,
Okay, then.
I
Thank you,
would
Lokesh.
like to sorry for inconvenience.
No, Lokesh, we are all learners here. You can proceed if you need. Do you wish to
No,
proceed?
I don't. No.
Okay. Thank you,
I
Lokesh.
just marked up all the points, so I don't want to.
Okay. We'll try next time. Okay.
Yeah, thank you.
Thank you, Lokesh. Next, I call upon Tata Usha to add her experience and insights to the topic. Over to you, Tata Usha.
Thank you, ma'am.
Yes, you may proceed. You're audible.
Hello, everyone. Good evening. Myself, Tata Usha, from Form D third year, Sri Padmavati School of Pharmacy, Tirupati. Now I am sharing my experience. My online experience for antimicrobial resistance. As I observed that in pharmacy stores, they are giving the antibiotics and combinations of antibiotics. How MG is that they did not matter that they're giving without the prescription of a doctor or any importance of any um, any call for the doctors also. By this, we will face the resistance in our body by using antibiotics for unwanted also. For um, my, my experience for like that, for cold and cough also, we are using the antibiotics and combinations. It will be develop the resistance in our body. So I think that it will be causes resistance to the antibiotics for another diseases also. So I think that in pharmacy stores, the pharmacist should be aware of this to explain to to the peoples about this disadvantage. As we are the pharmacists, we have to awareness about it. It will cause, resistance will causes the antibiotic usage decreases in our body. Yeah. So we have to aware the peoples also in our society, in our community, like our parents, relatives, friends, etc. I think this was observed that can anyone face this situation in your lives? Can I know about it? Can anyone please? Okay, thank you. Any questions?
Okay. What is your opinion about combination therapy and cross-resistant development?
Um, Antibiotic resistance. Combination drug therapy. Um, the two drugs. Like
यार मैं
antibiotic.
मीटिंग चला रही थी तो जो
Ma'am,
No, you may proceed. I think somebody unmuted themselves.
ma'am, I did not understand.
If you're not speaking, please unmute yourself.
Okay, thank you.
You may proceed, Tata Usha.
Guys, if you cannot speak, please don't disturb others, okay? Please put your mics off, everyone. Put your mics off and let them speak.
You may proceed, dear. Proceed.
Yes, ma'am. Combination drug therapy. If any two antibiotics having same mechanism of action, we will give them in combinations because they increases the efficacy of the drug, and it will be more efficacy to treat the diseases in the patients also. And cost resistance, by using the combinations, antibiotics, we will face the problem called cost resistance. For example, if we use an antibiotic which will be cause resistance in our body, it will cause um, another antibiotic also which having the same mechanism of action or same mechanism of action.
Okay. And what do you know about Red Line Awareness Campaign?
Mom, it is the campaign to awareness to aware the peoples about the usaging of antibiotics, mom. It
Okay,
is
then.
even in tablet sheet we will observe the light, red line in the back of the sheet. By using, we have to aware the peoples to don't take tablets having that red mark, because it will be decreases the resistance of the antibiotics. So to aware the peoples, the red line campaign is provided.
Okay, thank you, dear, for sharing your perspective.
Thank you, ma'am.
Now,
Thank you for giving this opportunity.
okay, thank you. Now, let me call our final panelist, Insha Noor. Guys, a gentle reminder, we'll be sharing the quiz link soon, so stay tuned with us. Now, you may proceed, Insha Noor. Over to you. Noor, are you there?
Yes, I am. Am I audible?
Yes, you're audible. You may proceed.
Okay. Good evening, fellow interns and Dr. Ajit Singh sir and everyone else who's present here from the CLIMAT team. I am Insha Noor and I am a third year pharmacy student at Nizam's Institute of Pharmacy in Hyderabad. And I am here today to speak about a case of extrapulmonary TB that has occurred in the lymphatic system of a patient. Can someone tell me where, as in what places can TB occur other than the pulmonary region or your respiratory system? If anyone can answer. Okay, miliary TB, yes. Lymphadenitis, yes. We also have pericarditis, we have meningitis, we have Coats syndrome. So yeah, tuberculosis can survive in other parts of your body other than the respiratory system also. So before I, get deep into the case that I am here to share today, I would like to remind you guys that sometimes TB goes undetected for a very long amount of time, which is known as latent TB. So this particular case that I'll be sharing is a case of latent TB. So this patient, aged around 36 to 35 years old, we don't have a confirmed age because she has gone through amnesia problem. So there is no confirmed age about her. So this woman was brought in to the hospital with complaints of having swollen lymph nodes in the submandibular region of her body. She had like big, swollen, red, painful lymph nodes. And initially, the doctors, she went to the doctors that are available in her local area. So they misdiagnosed the case and thought of it to be a general infection or allergic reaction, and they dismissed her, giving her a few paracetamol tablets and normal, antimicrobial drugs, and it was called off. Now, this patient started taking those drugs for a long period of time, but when she did not find any improvement or betterment in her case, that is when she came to the hospital to us with the complaint. Now, when this patient came to us, let me remind you guys, this was long after she had her initial symptoms. So it was already spreading throughout her body. So the first thing we could diagnose her with was the cervical lymphadenitis. We thought of it to just be a normal lymphatic system infection because she had most of the symptoms of that type and not the TB thing. And then we subjected her to multiple tests. We asked her to go for blood culture test. We asked her to go for uh, LFTs, RFTs, and then we also did a Montauk's test or Montauk's test, however you want to pronounce it. And this test, guys, came out negative. We repeated this test once again, and the result was the very same, negative. So the TB was for now ruled out of the picture because the tests were negative. Even the culture reports came out to be negative. Like I said, this is a latent case of TB. It went undetected for a long amount of time. And this swollen lymph nodes thing kept increasing. Now she started developing swollen lymph nodes in her groin area, in her underarms, in her thigh region. So this kept happening. So we had to repeat on another Montauk's test, and this time we also asked her to go for the biopsy of the swollen lymph nodes through the expert MTB/RIF test, in which the sample of her tissues were taken from the swollen lymph nodes and subjected to the test, through which here guys Montauk's test again came out to be negative. But the biopsy that we asked the patient to undergo, this test came out to be positive, and then the final diagnosis and the correct diagnosis was made that the patient had lymphadenitis tuberculosis. Now, this patient, when we subjected her to the first line drugs of tuberculosis, that is rifampicin, isoniazid, pyrazinamide, and ethambutol, she showed large amounts of resistance. The infection kept spreading, and her body kept rejecting all sorts of drugs we gave her. She had hypersensitivity reactions. She was not doing well. Her liver functioning was going down. So for a period of time, the drugs were stopped, and we had to shift to second line drugs, where we gave her uh, corticosteroids, and we had to give her second line drugs like amikacin and uh, what do you canamycin, and we also gave her capreomycin. Now these were the drugs we shifted the patient to, and we saw a little bit of improvement. But then again, after a few days, her body started to, reject these drugs as well. She now had developed, she now had developed pre-extensive tuberculosis infection in her body. Uh, Now we had to altogether stop all sorts of treatment because her body was her body health was completely deteriorating, and the infection was spreading, and she was showing large amounts of toxicity, and because of which her liver functioning was going down, her renal functioning was going down, and she was having hypersensitivity reactions, and she shortness of breath and all sorts of disease, all sorts of symptoms. So we had to stop the treatment for a long amount of time. Where she was shifted to, you know, vitamin B6 and vitamin supplements. Now, can someone tell me why we had to, give patients large amounts of vitamin B6 in middle of the ongoing treatment, if anyone can? Vitamin B6 is pyridoxine. Yes, Mohit, right. Side effect of isoniazid. We shifted her to large amounts of vitamins to restore her health back to a certain extent. And now the patient was treated only through IV or injection means, using the second line drugs such as amikacin, capreomycin, and we gave her canamycin uh, once a day, something like that through IV. The patient is still undergoing treatment. She is not completely cured. So there is a large amount of resistance we are facing now as well. And you can say that the infection is neither spreading nor is it reducing, but it is still there. So yeah, that was my experience with extrapulmonary tuberculosis or cough, that is
Okay.
epididymitis.
Please unmute yourself if you're not speaking. Please.
Sorry?
Okay, Noor, I have a few questions to you.
Yeah,
What
sure.
is the guideline for the treatment of extrapulmonary tuberculosis?
Yeah, for the guidelines to be set, we need to understand that we have three main principles or three main requirements that we need to, make sure are covered before we develop any sorts of principles. That is whether or not the patient has HIV, whether or not the patient also has an active pulmonary tuberculosis, which can possibly spread into her body, and whether or not he or she has availability of good diagnostic tests like biopsies and blood culture tests. So, based on these three requirements or principles or conditions, we have certain principles which would be early diagnosis and then correct diagnosis. The patient first, or the policy where patient has all the rights to know about I'm sorry, his or her disease, what kind of treatment they'll be undergoing, what procedures are to be followed, and we also have to check if the patient has HIV or any other autoimmune disorder because of which tuberculosis could have come into picture. Or we also check for pulmonary TB, and then we make sure the patient adheres to the set routine by the physician, and the routine is correct, and there is a proper correct duration of the treatment. Yeah.
Okay. What will be the effectiveness of second-line anti-tubercular drugs in case of resistance, in your opinion?
Yeah, see, it depends on the kind of resistant tuberculosis the patient has. Like there are different kinds of uh, resistant tuberculosis. We have MDR, we have uh, XDR, and then we have pre-XDR. So depending on that, uh, we can or cannot use second line injectable drugs or second line oral drugs for TB. But if you ask my personal opinion, I would say when the first line drugs itself are not, being any majorly helpful in such cases, I don't think the second line drugs would be helpful. So you'll have to go half and half, and you know, prepare a combination of drugs which will help the patient depending on the case, of course.
Okay, final question. What is multi-drug resistant tuberculosis and extensive drug resistant tuberculosis? Will you explain in short?
Yeah, sure. So these are two different types of drug-resistant tuberculosis that occur in the body. So multi-drug is where from the first-line drugs, any one drug, plus isoniazid and rifampicin. These three drugs, that is any one drug from the first-line drugs, isoniazid and rifampicin, these three drugs are being resistant by the tuberculosis. And when it comes to extensively, what was that again? Drug-resistant tuberculosis, you have fluconazole plus isoniazid plus rifampicin and any other injectable, second line injectable, which could be amikacin or kanamycin. These are the drugs that are being rejected by patient or the patient's body.
Okay, thank you, Noor.
Thank you. Thank you, guys.
Okay. Lokesh, are you willing to do now?
Yeah.
Okay, then proceed.
Uh, I wanted to start with how bacteria acquires resistance. Basically, there are two mechanisms by which bacteria acquires resistance. One is natural resistance, and other one is acquired resistance. What is in natural resistance? There we know bacteria are of two types: gram-positive bacteria and gram-negative bacteria. Gram-positive bacteria contains a high peptidoglycan layer, whereas Gram-negative bacteria contains a thinner peptidoglycan layer with an outermost inner inner teichoic layer. So what happens when how gram-negative bacteria is the one which acquires a resistance through natural mechanism for penicillins. Penicillins, what they do, they destroy the peptidoglycan layers of the cell wall of bacteria. Let's move towards the acquired resistance. In acquired resistance, there are three main factors by which a organism or by which a microorganism acquires resistance. First one, it is mutation. Second one is uh, alteration of the target binding site. Third one is the enzymes, enzymes, and the last one it is how argin affects the target binding site. First, we will move towards the mutation. Mutations are of two types: vertical mutations and horizontal mutation. In vertical mutation, the bacteria acquire resistance due because of the longer exposure of the antibiotics and uh, alteration of the genetic materials of second genetic material, which is plasmid. In horizontal resistance, the bacteria transfer the microorganism transfer argin from one organism to the other. So the incorporation of the plasmid from one organism to the another causes the resistance through horizontal mutation. Next, in horizontal mutations can occur through three processes: conjugation, transduction, and transformation. Now we would move towards drug destroying. The drug can be destroyed by two mechanisms for such as beta lactamase enzyme in staphylococci, Haemophilus influenza, gonococci. These bacteria, they do what? They secrete an enzyme beta lactamase so that they destroy the beta lactam rings of the beta lactam antibiotics. Beta lactam antibiotics example, penicillins and cephalosporins. Next, the bacteria acquires resistance through cross resistance. Means one strain of the bacteria transfer their genetic materials through transduction, conjugation, or transformation into the other strains of the bacteria. Now, uh, what would be the consequences if antimicrobial resistance occurs? First of all, the treatment procedure would be a very long. The patient will the patient in the patient won't be able to take the treatments because of high exposure, because of not availability of cheaper antimicrobial agents such as azithromycins or amoxicillin. We need to focus on the last resort antibiotics. Second, patient will be patient will be hospitalized even for a smaller infection such as sore throat, and also for cough and cold, which is not necessary nowadays. But if all the microorganism leads to develops resistance, then it would be like we will be going hospitals for sure complaint of sore throat also. Next, high cost of healthcare due to more investigations. Diagnostic investigation would be required more and more so that we can find the most suitable antimicrobial agent. Let's now drivers of whatever you want to call drivers, factors affecting the antimicrobial resistance. First of all, the most prominent one is misuse and overuse of antimicrobials. In misuse, like we all know, physicians do not prescribe any antimicrobial agent without their proper diagnostic investigation, but BHMS doctors, they prescribe antibiotics even for a small complaint of cough and cold. This leads to the misuse of the antibiotics, improper diagnosis, and also overuse of the antimicrobials. In this, OTC medication also renders the diagnostic test so it also affects the diagnosis. Next, lack of access to clean water means we are drinking contaminated water daily. Sanitization and hygiene is not proper in both animals and non animals, humans and plants. Poor infection control in healthcare system, such as it is not hospitals are not sanitized properly, nosocomial infection, vaccinations are not taken. This may lead to the develop the antimicrobial resistance in the microbes. Uh, let's how we will be selecting antimicrobial agent if we are concerning about resistance in the antimicrobes. First, we need to identify the organism, which organism it is on the basis of the diagnostic tests such as Vidal test, ELISA, RT-PCR, modal IOFT, everything, so that we can give up antibiotics for the suspected infection only. Next, we will be thinking about susceptibility of the organism towards the antimicrobial agent. How we can check that? Basically, we are having two types of antibiotics or antimicrobial agents. One is bacteriostatic and the other one is bactericidal. Bacteriostatic anti antimicrobial agents includes chloramphenicol, erythromycin, clindamycin, sulfonamides. Bactericidals includes broad spectrum antibiotics such as vancomycins, linezolides, and others. Difference between the bacteriostatic and bactericidal is that bacteriostatics do not kill kill the bacterium, but it only arrests the growth and replication of the bacteria at drug serum level. Uh, there are many antibiotics which are both bacteriostatic and bactericidal, but the main difference it is dose dependency. For example, aminoglycosides, fluoroquinols, metronidazoles. Uh, uh, or also there are factors such as one antimicrobial agent can be bacteriostatic for one organism and bactericidal for other organism. Linezolide is a bacteriostatic agent for Staphylococcus aureus, whereas it is an bactericidal for Enterococci strains. Next, for testing, so for susceptibility testing of the antimicrobial agent, we have performed these experiments in the microbiological lab. It is known as MIC, minimum inhibitory concentration of antimicrobe. In this, it is the lowest concentration of the antimicrobial agent that prevents the growth of the organism after 24 hours of the incubation. Apart from MIC, we can perform MBC, which means minimum bactericidal concentration, which is lowest concentration of the antimicrobial agent, where 99.9% of the bacterium growth or colony is declined overnight incubated. Thank you. And sorry for the inconvenience.
No, Lokesh. Thank you so much. And I appreciate your positive spirit to try once again. Well done. Keep going like this. Okay. And now we'll be uploading the feedback form and the quiz link soon. So have an eye on the chat box. I thank all the panel members for the impressive communication on the critical information you have brilliantly portrayed. Thank you, guys. May I proceed to the vote of thanks? Okay, as we conclude our today's session, I would like to thank a moment to express my sincere gratitude to each one of you for your active participation and valuable contributions. I would like to thank our networking club for organizing this session and all other clubs like social media club, editorial club, organizing club, hosting club, and scientific club for their constant and valuable contribution and cooperation in making this virtual event a successful one. I would also like to thank the team who worked behind meticulously for the seamless execution, ensuring that this virtual event went smoothly from start to end. To all our attendees, thank you for your engagement and questions. Your enthusiasm and involvement have made this webinar truly interactive and impactful. Once again, thanking you all for your invaluable contribution. Let's carry forward this same momentum in the further sessions also. Thank you, guys. Please do participate in the quiz competition and do fill the feedback link.